Hi everyone, welcome back to class. Today we're going to finish up talking about GABA. So this is the same PowerPoint slide file as Monday's GABA lectures. So we're on slide 17 now, in case you were wondering. So let's start by talking about the GABA receptors. There are two classes of GABA receptors. I'm sure you can guess, but one class is ionotropic receptors, and then we've also got metabotropic receptors. So the ionotropic receptors we call GABAa receptors, and metabotropic receptors we call GABAb receptors. So GABAa, GABAb. GABAa are classic ligand-gated channels that allow in chloride. We talked about that before, and that's what makes it an inhibitory neurotransmitter. There are 5 subunits that form the channel pore. In other words, there are 5 proteins that come together to create the receptor. And originally, the GABAa receptor was characterized by its sensitivity to bicuculine, however you want to say it, which is a competitive antagonist of the GABAa receptor. So we'll talk a little bit more about that drug in a bit. The GABAb receptors are G protein coupled. They tend to be GI, so they inhibit adenylate cyclase, so they decrease CAMP. My cat is very mouthy today, so he will be giving commentary in the background. These GABAb receptors are also G-beta gamma. That just means that they open G protein coupled potassium channels, so GERK. Really, I would just call them GI. Know that the G-beta gamma isn't quite as important. Originally, these GABAb receptors were characterized by their sensitivity to baclofen, which is a specific agonist. So let's get into the receptors one by one. We've got the GABAa receptor. So here you can kind of see those 5 subunits. So there's 1, 2, 3, 4, 5 subunits here. You'll notice that they're labeled. We've got 2 alpha 1s and 2 beta 1 GABAs, and then there's a gamma 2, I think that is. But there's these 5 subunits, and it's a combination of 19 different genes that create these subunits. So there's actually 6 different types of alpha subunits, 3 different types of beta subunits, and 3 different types of gamma subunits. And they're made up of a number of different genes. And then there is also these other types of subunits available. So delta, theta, I believe sigma, pi. And then there's also 3... That's not psi. That might be psi. 3, we're going to call them 3Ps because I can't remember that Greek today. 3P subunits as well. Okay, so a normal channel will have at least 1 alpha and at least 1 beta subunit. And then there'll be other subunits. Now, the most common form of the GABAa receptor is this one right here, where we have 2 alpha subunits and 2 beta subunits, and then a gamma. This is the most popular, but there are some cases, obviously, where you can switch these out, but this is just the most common. Okay. Now, there are some special cases where we can actually get a GABAa receptor that is actually made up of just these P subunits, okay? So those are very special cases, so you don't really need to know them too much, but just know that that is a thing. Is that rho? That might be rho. I don't know. But we'll continue. Okay, so know that most common there's going to be alpha and betas and maybe one gamma. But you can figure it out. Okay. So moving on, this is how I just picture the receptor. You know, it's an ionotropic receptor, so it's a channel. So this looks very similar to other channels that we've seen, especially that glutamate receptor, ionotropic receptor. So there are multiple binding sites again, so we are going to talk about all the different binding sites and what's going to happen. Okay, so there are 4 binding sites for endogenous and exogenous ligands. Okay, so first we have the GABA site. Okay, so that's this one right here. It's the little yellow one. That's the GABA binding site. So 2 molecules of GABA can bind there, and that's in between an alpha and beta subunit. So if we go back a slide, you can see right here where we have GABA labeled. So in between an alpha and a beta, then a GABA can bind. So it can bind right there. The maximum that GABA is going to bind is 2. So technically, you know, a GABA could probably bind here, but it's not going to. Okay, it's going to bind at those 2 spots, and only 2 GABAs will ever bind. We then also have a benzodiazepine site. Okay, so that's this one here, this little green one. This binds benzodiazepines, or tranquilizers, and they act as positive allosteric modulators. Okay, so they're going to increase the probability of this opening. We've then also got a barbiturate site. So that's this little orange one here. So this is where barbiturates will bind, obviously, and again, it acts as a positive allosteric modulator. Now, the last binding site of these endogenous and exogenous ligands would be the neurosteroid site. So it's this one way back there. And that is where endogenous neurosteroids are going to bind. And again, those can act as positive allosteric modulators. However, neurosteroids can also act as a negative allosteric modulator. Okay? So neurosteroids can act as either positive or negative. There is then also this molecule right here, picrotoxin. So picrotoxin is a non-competitive channel blocker. Okay? So it's actually derived from the seed of a climbing vine. And it's both a stimulant and a convulsant, because what it can do is it can block GABA. But it can also be used to counter barbiturate poisoning. So it's shown here being there, but obviously picrotoxin won't be there normally. That's only when it's taken, then that's where picrotoxin binds. It blocks that GABA from working and opening this channel, because picrotoxin will block the channel from the inside. And that's good for when we talk about potential anesthesia or overdoses from barbiturate poisoning. Okay, so we've got non-competitive sites. So some example would be pentylentetraxol, which binds at the same site as picrotoxin, and it can be used as a convulsant for depression therapy. Now, obviously, we don't use that anymore, because why would we want to give people convulsions? Also, it had a high risk of spontaneous seizure production. So rather than only having seizures or convulsions when we want them, when we give them this drug, it would then lead to kind of long-term increased risk of these spontaneous seizures. So in general, it was replaced with electroconvulsive therapy in 1939. And as you know, electroconvulsive therapy is today sometimes still used, but it's definitely not in the top 3 or 5 choices for depression therapy. At the GABA site, then we've got the competitive antagonist bacucoline that I mentioned. This is a very potent convulsant. Okay, we see it used a lot of times in animal models of epilepsy. Specifically, we use this to induce epileptic symptoms in animal models so that we can then treat it with potential AEDs. The classic agonist for the GABA site would be muscimol. So this one would be anticonvulsant. Okay, so it's going to increase the probability of that GABAa receptor opening, whereas bacucoline will decrease that probability. Okay. Personally, I have used both of these drugs in animal models. I was doing it in some pigeon research where we were trying to identify the types of neurons that were involved in certain visual discriminations in pigeons. So seeing how they tell the difference between or make decisions about if something is in a figure or the foreground or background, so foreground versus background, or if something is shape A versus shape B, what type of neurons are involved in that. So we use both bacucoline and muscimol to see, is it a GABAergic neuron, and then we use other drugs to see if, well, maybe it's a glutamatergic neuron. So that's how I've used it. But we can also use it for epilepsy. So these drugs can be used for epilepsy experiments or just trying to figure out the types of neurons involved. So the source of muscarinic acetylcholine receptor agonist muscarine, the source of GABAa agonist muscimol. Okay. So muscarine and muscimol are related. Okay. It can act as a potent hallucinogen, and it makes the perception of objects appear larger than they are in high doses. It does come from a fungi, so that's why we've got a beautiful mushroom sitting on over in the picture there. So you can see what it comes from. And consumption of fly agaric has serious peripheral side effects due to these muscarinic cholinergic effects at the neuromuscular junction and its parasympathomimetic effects. Okay. There is a synthetic version of muscimol that we can use as well. So that is gaboxidol. It does pretty much the same thing as muscimol, however, it doesn't come from this fungi. It is an anxiolytic and an analgesic. So it was first investigated for insomnia treatment. It really just, these synthetic versions help us kind of more specify what the drugs are doing and eliminate any potential negative side effects that the normal non-synthetic version would have. So you might have heard of fly agaric before, or Amanita muscaria. It was used by indigenous cultures in Serbia and other places nearby, and it has been proposed that it is the mushrooms in the source of soma, which is a Vedic ritual drink used in the early Indo-Iranian cultures. It's also proposed that early Christianity may actually have sprung from cultic use of fly agaric in Second Temple Judaism, as it can produce this sense of transcendence, so that's an entheogenic effect. And in some Serbian indigenous groups, then they'll use this drug for ceremonial purposes, and it's also actually been observed to be consumed by reindeer. And it's thought that this may actually be the source of the myth of flying reindeer, is reindeer eating these drugs. And when they when they're intoxicated with these mushrooms, then they kind of like jump around and stuff, and it kind of gives the idea of flying reindeer. They're not actually flying. Oh, that is not what I wanted to do. Very sorry. So lots of historical use of fly agaric is very important for the cultures around where it grows normally. And it just has such a cool history. Okay, let's move on then. Okay, so we have mentioned benzodiazepines and barbiturates. Both have a binding site on the GABAa receptor. Now, you've probably heard of both of these drugs before because they are used as anxiolytics. They help decrease anxiety. Benzodiazepines, let's start with what are those. You can also call them BZs or BZDs or benzos. Lots of different names because benzodiazepines, a little bit of a long name. One of the most well-known benzos would be Valium. Valium's name is diazepam. Again, probably heard of it. It does have a pretty good safety margin, especially when we compare it to barbiturates, which I will get to in a minute. And binding of benzos to these GABAa receptors increases the probability of that pore opening. So it increases the risk of the chloride ions entering the postsynaptic cell. Okay. Now, there is a high risk of drug interactions at the GABAa receptor. Okay. So that just means that because there's so many different receptors at that GABAa, or different binding sites on that GABAa receptor, then a lot of different things can go on. So just having a benzo binding doesn't necessarily mean that this receptor is going to open, because it has to do with all the other things going on. Now, we do call the benzo site an orphan receptor site. And that's just because we don't know really why there is a benzo binding site. There is no endogenous ligand known that our body naturally produces that would make sense why our body has then created this binding site, right? Like, why is there a binding site for something our body doesn't naturally make? We have to ingest benzos in order for them to bind. Now, it is proposed that ligands include inosine and peptides, such as diazepam, can bind there, and that there may be some inhibitor acetyl-CoA binding proteins and small molecules that can bind there. We call those endozapines. So they're not the typical ligand that we would think of, like, our body makes GABA, our body makes glycine. But why then is there a benzodiazepine site that, if our body doesn't naturally make a diazepam or something, right? So there are these small molecules or these binding proteins that seem related, but we haven't been able to show outright that yes, that is their function normally. Okay. Now, it is thought that perhaps there are some sort of endogenous anxiolytic molecules that bind here, but again, we're not sure what those are. It's been difficult to figure out. Now, on the other side are barbiturates. So barbiturates are anxiolytics, but they're also sedative and anesthetics. Okay, so people tend not to be prescribed barbiturates for anxiety. Barbiturates are usually prescribed or used for anesthesia or some sort of sedative effect. effect, mostly because it has a narrow safety margin. It's very hard to maintain these drug levels and not go into an overdose situation or all that kind of stuff. You know what a safety margin is. We talked about that in Unit 1. Barbiturates also have a high potential of abuse, just because they do kind of numb everything, and so that's very, very addictive to some people. Phenobarbital is one of the best known barbiturates. It's still out there. It is used in some clinical settings for its sedative hypnotic effects, not as an anxiolytic. Binding of barbiturates to its binding site prolongs the opening of the chlorine pores. Okay, so that is different than what the benzos do. Benzos increase the probability of the pore opening, whereas barbiturates just keep that pore open longer. Okay, so they actually do two different things at that GABAa receptor. Barbiturates have been used in the past for physician-assisted suicides and euthanasia. Barbiturates can be used in research for animal euthanasias because it is, they just go to sleep. It's more humane than other methods. There is truth serum. So sodium amytal is a barbiturate. It's known as truth serum. It doesn't really make you tell the truth. It just lowers your inhibitions. So you're more likely to tell the truth because it decreases that inhibition you have. Okay. You can still lie with the truth serums. You can actually have false memories. So kind of like with hypnosis, you're really just more suggestible. So if you take it and then someone's like, ooh, didn't you see that? Then you're like, yeah, sure, I saw that, even though you didn't. Okay, you're just more susceptible. So you're more susceptible to tell the truth, but you're also more susceptible to agree to a lie. So not really truth serum. Okay. We're going to do one more slide just so we can finish up the GABAa receptors. So there are some other interactions that can happen at the GABAa receptor. One is with ethanol, so alcohol. This is a positive allosteric modulator of the GABAa receptor, and it binds to a site on the transmembrane surface of the what is that? Sigma delta unit? No, that's delta. The delta subunit. Why would I doubt myself? It's delta. So, in other words, ethanol can bind to that delta subunit if it's there. Okay. So it exerts many sedative and euphoric addictive effects because of its modulation of this GABAa receptor. So ethanol will bind with very high affinity to the GABAa receptor, and even at doses that would be considered moderate, so like social drinking levels, so like 1 or 2 beers, it's still going to bind very well to these GABAa receptors. You don't need a lot of alcohol for it to bind and start having some of those effects. And that's why people, you start to see effects even after 1 or 2 drinks, and why they say you shouldn't drink after, a certain amount, because it really doesn't take much at all for it to start affecting your inhibitions. Okay. And then finally, we've got propofol. This is a very potent anesthetic that interacts with the transmembrane surface of the beta subunits of GABAa. This is a positive allosteric modulator that leads to an increase in the channel open time. So that's similar to a barbiturate. Okay. So it's very, having that open too long, that means that now we can't kind of reset. We get extreme inhibition. when maybe we don't want it that long. There is a famous case of drug interactions at the GABAa receptor, would be Michael Jackson. He died as a result of a dose of 2 different benzodiazepines, diazepam and lorazepam, and taking this anesthetic propofol. So pretty much his 2 benzodiazepines highly increase the probability of the GABAa receptor opening, and then propofol increased the opening time. So pretty much the GABAa receptor was just open all the time, and so you got this prolonged inhibition that, remember, when you take a drug, it works everywhere, not just one spot. So you need to turn off inhibition eventually, and just by mixing these drugs together, that wasn't able to happen, and that's what led to this death of Michael Jackson. So that is it for the GABAa receptor. We will continue in the next video for the GABAB receptor.